Proliferation markers. Marker of proliferation such as S phase fraction or cellular expression of Ki67 or MIB, which measure the percentage of cells in GI, this G1 phase of cell cycle, and mitotic index. They are powerful prognostic factor in early stage breast cancer. However, inter-observer variability and lack of uniformity thresholds for clinical prognosis preclude reliance on this measure as a sole determinant of decision. Molecular and genomic factor. Basic breast cancer is a heterogeneous disease, and it has long been appreciated that tumors with different biological features have different clinical outcomes and response to therapy. At present, prognosis and treatment selection in breast cancer, they are based on characterization of the tumor growth factor receptors such as ERP or HER2. These markers can be used to define four functional group of tumor: hormone receptor positive, HER2 negative, hormone receptor negative, HER2 negative tumors, triple negative tumors, and HER2 overexpressing tumors with or without hormone receptor expression. Molecular studies have demonstrated that these subsets are defined but distinct genomic and gene expression profile. Sorley et al. And Peru et al. Classified breast cancers into tumor subtypes and that had different prognosis using complementary DNA microarray. The differences in gene expression patterns among these subtypes reflect basic differences in the cell biology of the tumor and are manifest in differences in clinical outcome. Clinicians are increasingly viewing these molecular subtypes that are separable disease, and the subtype of luminal A, luminal B, HER2 enriched and basal-like or basaloid triple negative. The subtypes are commonly approximated using routine tumor markers such as luminal A, ERPR positive, HER2 negative with low-grade features, luminal B, ERPR positive, HER2 with higher grade features or HER2 positive, ERPR negative, HER2 positive, and basal-like ERPR negative, HER2 negative. And the difference in gene expression patterns affecting hundreds of genes are found in between various subgroups. These differences appear to persist through the natural life history of the breast cancer, and neoadjuvant treatment of breast cancer tumors appears to have a little bearing on the gene expression pattern that contribute to intrinsic tumor subtypes. Subgroup affect both the likelihood and timing of cancer recurrence. Triple negative basal like HER2 associated and luminal B breast cancers, they are at greater risk for early recurrence relative to luminal A cancer, which have a longer latency period of positive recurrence. Complete genomic sequencing of human breast cancer has reinforced the clinical observation that tumor defined by biomarkers have distinct genomic signature and confirm strong correlation between histological subtype of breast cancer and pattern of gene expression and genomic mutation identified by genomic sequencing. And this information is increasingly influencing clinical practice. International consensus now recognizes that breast cancer should not be treated as single disease. Rather, patients should be stratified for treatment by molecular subtypes using genetic array testing or approximately by ERPR HER2 stages, possibly together with markers of proliferation such as Ki67. In addition to defining biological tumor subset, gene expression profiling has been used to stratify tumors as having good risk, poor risk prognostic signature, and mama print is a 70 gene signature developed in the Netherlands, and Prosigna is nanostring technology, Seattle, Washington, and is a 50 gene intrinsic subtype classifier that categorizes cancer into luminal A, luminal B, HER2 enriched basal like subtype, Prosigna. Retrospective analysis suggests that these gene signatures contribute independent prognostic information above and beyond that achieved with the use of traditional pathological markers such as stage, grade, lymphovascular invasion, HER2 status. This genomic assay have proven especially valuable in distinguishing the prognosis within the subset of luminal HER2, ER positive, HER2 negative breast cancer, which are the most common form of breast cancer. Oncotype DS is a recurrence score which is based on the 21 genes thought to be relevant to breast cancer biology, including hormone receptor Ki67, HER2, among other. In contrast to gene expression profile that classify tumors into specific subset of or dichotomize the tumors into good or poor prognosis, recurrence score calculate continuous numeric result that correlates with the distinct metastatic recurrence in postmenopausal women with node negative or node positive tumor receiving either tamoxifen and or AI. Although the recurrence score tends to correlate with the features that tumor grade Ki67 quantitative levels of hormone receptor expression, score provides significant independent prognostic information, and as discussed later, Oncotype DX has proven particularly valuable for determining whether a patient with ER positive breast cancer should receive chemotherapy in addition to hormone therapy. And there is a substantial overlap between the various molecular diagnostic assay used to gauge a prognosis and treatment for early stage breast cancer. In particular, many assays appears capable of distinguishing node negative low grade tumor that are strongly ER positive and HER2 negative and are unlikely to benefit from adjuvant chemotherapy. For instance, MammaPrint has been shown to identify a group of patients with low risk tumors defined by both traditional clinical feature and by the genomic test who do not benefit from chemotherapy in addition to endocrine therapy. Collectively, these molecular tools have led to evolving of staging specific treatment algorithm based on the subtype classification plus clinical trials that are designed for specific clinical subtype of breast cancer. So, association of clinical pathology features of breast cancer with intrinsic subtypes. Intrinsic subtype ERPR expression, luminal A strong positive, luminal B positive variable. So in luminal A, that is ERPR positive, HER2 amplification is rare, grade is low to intermediate, P53 mutation is rare, Ki67 is low, and DNA copy number diploid. mRNA expression signature high ER cluster, low proliferation. In luminal B, there is ER positive, HER2 rare, though small percentage positive, grade is intermediate to high, P53 is uncommon, Ki67 is also intermediate to high, and DNA copy number is aneuploid. mRNA expression signature lower ER cluster and high proliferation. HER2 enriched is positive for positive or negative ERPR expression. HER2 is common, and there is intermediate to high grade. P53 is also common, and Ki67 is high with DNA copy number is aneuploid, high genomic instability. mRNA expression signature high HER2 amplification and high proliferation, and basal like is negative for ERPR, negative for HER2, high grade, common P53 mutation, high Ki67, aneuploid, high genomic instability, and mRNA expression is basal signature high proliferation. Thank you.